Welcome and good morning. I appreciate you making time to be here with us at this Colorado Health Cabinet Health Policy Summit hosted by HCPF. My name is DJ Wilson. I'm the publisher and CEO of State of Reform, and we get to be part of the group that's bringing you this summit today. It's been quite an effort on the part of HCPF. The team at Kim Bimsteffer and others at the agency have been working on this event for about a month to try to turn around a thoughtful conversation with really a very wide range of folks, including, of course, about 1,600 people registered to be with us today. So I just want to give you a little bit of a logistics tour as we head into this conversation, and then I'm going to jump right in and introduce some of our morning speakers. So first, as you can see on the right of the video here is a chat box, and you're welcome to post your questions. This will all be a live and interactive experience. Many of those questions will be integrated into our conversation throughout the day, but of course, we expect that there'll be more questions and more comments than we'll be able to get to, just because of the logistics and all of the content that HCPF has to share. So the agency has said that they will put together an FAQ, basically a selection of questions that you pose in the chat box, and make that document available after the fact. So you'll be able to pose your questions and your comments, to respond in real time, and of course, have those answered either today or often afterwards at the FAQ. I'll also let you know that we'll be taking your sort of a sense or a pulse of your thoughts today via poll questions. It's a way you can continue to be interactive and engaged with us, and we can make sure that we're getting your direct and real-time information, both just in terms of who you are, basic demographic information, but also what you think about some of what you're hearing today. So we got a lot of moving parts at play, a lot of really fabulous speakers from the Health Cabinet, and we're excited to have you with us here today. So without further ado, let me just jump right in and introduce the sort of introducer of the whole thing, which is the Lieutenant Governor, Diane Primavera. We appreciate your role in all of this, Lieutenant Governor, and being here today. Why don't you take it away?
Thank you, DJ, and hello and good morning, everyone. Thank you all for joining us virtually today. On behalf of the Polis Primavera administration, I'm thrilled by the outpouring of interest and support. As he said, we have over 1,600 stakeholders joining us today to learn how we're approaching health policy in Colorado. The message is loud and clear. Coloradoans and the majority of Americans want to see action on healthcare. Employers, state leaders, and people across our state struggle under the weight of the rising healthcare costs. And since the day we took office, one of our administration's bold 4 goals has been to save people money on healthcare. I was honored when Governor Polis asked me to lead the Office of Saving People Money on Healthcare, because I've spent my career advocating for patients. Our office works collaboratively with the legislature, our state agencies, community partners, and industry stakeholders to ensure our healthcare system works for Coloradoans. Our work was urgent even before the COVID-19 pandemic. Then, nearly 1 in 5 Coloradoans went without needed healthcare because it costs too much, and 1 in 3 Coloradoans could not afford their prescription drugs. But we know the pandemic has made this reality even worse. In April, about 35% of Coloradoans were worried about paying for their health care and found it difficult to pay for other basic necessities such as food, housing, and utilities. The pandemic has changed so many aspects of our lives, but it's not changed the need for affordable, quality health care. It's only provided a greater sense of urgency. We also know that COVID-19 has not affected all Coloradoans equally. We must continue to prioritize equitable access to quality, affordable healthcare and work to rectify disparities in health and wellness. Coloradoans must be able to access the care that they need without fear of financial ruin. Too many of our neighbors are choosing between putting food on the table and taking their prescription drugs. While I'm proud of the progress that we've made, the healthcare system we have isn't working for Coloradoans, and we will not waver in our charge to lower these outrageous costs so Coloradoans can support themselves and their families, so Coloradoans can contribute to our local economies, and so Coloradoans don't have to avoid going to the doctor when they need care. and so Coloradoans don't confront astronomically higher costs down the line. Joining us today are leaders and experts who will present some solutions surrounding these topics, including reducing prescription drug costs, furthering substance use and mental health prevention, treatment, and recovery, ensuring the success and well-being of our rural communities and rural hospitals, controlling healthcare costs for employers and their communities, and responding to the COVID-19 pandemic. So thank you for coming today to learn about our priorities and share ideas, but we can't solve the pressing issues of our day without you. We welcome you to join us in deviating from the status quo that is so unsustainable for our state and our neighbors. Let's work together to create change. And again, thank you for joining us.
Thank you, Lieutenant Governor. It's always such a privilege to have you with us, and the beacon that we all aim to during the storm. So thank you very much for your leadership and your experience and your passion. And it's a joy to follow your leadership. So with that, we're going to dive in as the Lieutenant Governor introduced. I'm sorry, go ahead.
Likewise, Kim.
Thank you. Thank you. So I'm going to dive right into the slides and recognize that we have a panel, as we said, a wonderful array of folks that are kicking us off this morning, are doing the presentations and hosting the panel. So I want to recognize Jill Hunsicker-Ryan, Executive Director of Public Health and Environment. I want to recognize the incident commander for the COVID work and vaccines, et cetera, who will join Jill in one of the sessions. Commissioner Conway is with us, John Bartholomew, our CFO here at HICPUF, and Dr. Robert Worthwine is here as well from the Office of Behavioral Health to host our session on that. And thank you again to the Lieutenant Governor. The array and agenda is tremendous. So we will talk, I'll kick us off with affordability priorities, a special focus on prescription drugs. I'll kick us off, or I'm sorry, the next session will be on prescription drugs from a state perspective. After that, prescription drugs federal perspective, behavioral health task force, rural hospitals, community investments, as well as employer sessions, and then a session on COVID, and then I'll bring us back to the closing. So a busy day, and we really appreciate y'all joining us today. So extra other guests, which are fabulous special guests, representing our providers. We've got the president of the Medical Society here in Colorado, Michelle Mills from our rural hospitals, Will Cook from Vail Health, CEO there. We are honored to have Senators Michael Bennick and John Hickenlooper here as well. Representing Optum, owned by United Health Group, is Marissa Schaeffler. And then Dr. Jerry Anderson, you might recognize that name. He's often testifying before Congress. He will join us on the federal conversation on prescription drugs and represent employers, Dick Monford, the owner of the Colorado Rockies, and Bob Smith. Also leadership from the various agencies and health cabinet, Carrie Pykoch, the director of the Office of Health Innovation, and from HICPUF, Tom Leahy, Nancy Dolson, Kristen Bates, and from the Office of Saving People Money, Caitlin Westerson. So a lot of special guests. Let's jump right in. First message, thank you so much. All of you are joining from the healthcare delivery side. Our healthcare workers, you have gone above and beyond, and we are honored and so thankful for the contributions that you are making during this downturn, during this global pandemic. We appreciate everything that you do every day. I want to call out some other items on this slide. We are now, as a state, 1 in 105 are contagious here in Colorado. I want to recognize the tremendous work we've done, that it used to be 1 in 40 just around Thanksgiving, so we have gotten better. However, in the summer, it was 1 in 1,200 contagious, so we have a long way to go to get back to where we were. The most pressing thing we can all do is get vaccinated until and up until that point, as a society, as an American population, as a Coloradan population. In between, please continue socially distance, wear your mask, wash your hands, to stay in compliance and move that contagious ratio down. You will see us focus today on trying to find policy and implement policy that removes the stranglehold that healthcare costs have on Coloradan families, our businesses, and the state Before the recession, it was the number one issue for Coloradans, and it was the number one issue for employers. And that has been exacerbated in reference to what the Lieutenant Governor said. 20% of Coloradans are concerned about feeding their family, losing their home, being able to pay for basic necessities. The state right now, healthcare policy and financing alone is 29% of the general funds, but combined with public health and human services, we now together are 36% of general funds. We want to recognize that through this recession, the unemployment rate has continued to rise, got up to 12.2%, and now is sitting at about 6.4% for the last several months. We know that for the lowest income Coloradans, that their loss of jobs was not equal to the rest. 25% unemployment around April. We are pleased that we've decreased that now to 7.5%, but that is still significant portion of our families who are struggling. And so when we think about policy, we want to focus on that community and society. Very different from the highest income individuals that are now at a 0.5% unemployment rate. December was not in a good place. We lost another as a nation, 140,000 jobs. We want to recognize 253,000 Coloradans are still on unemployment insurance. So what does that mean, and how does it relate to the public health emergency and the relationship with healthcare policy and financing in the state? We will continue to bang a drum at the federal level through the National Governors Association, our Alliance of Medicaid Directors, to encourage the federal government to continue the public health emergency until the majority of Americans and the majority of Coloradans get vaccinated. So we were fortunate just last week, Secretary Azar of HHS did extend the public health emergency 90 days on top of continuing after January 21st when it was due to expire. So as we have this public health emergency, we're not permitted, which is quite beautiful, for terminating anybody from Medicaid. We are keeping them on the rosters regardless of their eligibility during this public health emergency. It's a federal requirement, and we're grateful for the opportunity. Along with that commitment comes about $100 million a quarter. We will get another $100 million in the second quarter of this year because of that extension of the public health emergency. You can see the red line, that represents the growth of Medicaid expansion members, and the blue line is the growth of children covered by Medicaid. Traditionally, the children have always been a huge bucket at about 42% of who we cover, and we have the honor of covering little kiddos when they need us the most to stay covered. But if you look at that red crossing the blue line, that is remarkable in that the adults are growing at double the rate of the kids. And so they're actually surpassing kids, and that is pretty incredible. I also want to recognize that we're the second fastest growing state for seniors. And when the seniors are losing their job, those over 65, they are likely getting on Medicare. So I want to point out, while that is a high level, it's not high as we thought. Here are some concerning metrics. We have about 40% of the population who has lost their job and is on unemployment insurance that says, I am not going to get health coverage. I'm going to continue to not be covered. The good news is we have, of those on unemployment insurance, we have an 80% increase of the folks saying, hey, I'm coming over to Medicaid. We have about a continuation of about 9% of folks saying, I'm going to go over and get affordable care on the Connect for Health Marketplace exchange. But that 40% at the bottom in red is concerning. I want to thank everybody on the phone for their partnership and collaboration with the department and the health cabinet of connecting Coloradans who have lost their job to affordable coverage. But so that would be Marketplace exchange subsidies and Medicaid. Why is that important? Because when we surveyed the individuals who said they were not covered, they said it was because the premiums were not affordable. And because even if they could afford the premiums, they can't afford to get the care because the co-insurance and high deductibles are unaffordable for them. That is why we need to so much address affordability of healthcare, as the Lieutenant Governor said. The good news, we have a health cabinet, a lot of people working together with stakeholders on the phone to do three things. One is priorities this year, prescription drug costs, helping employers control costs, and also getting up and running the recommendations of the Behavioral Health Task Force. In Colorado, we want to take a leadership position in all of those. So from a behavioral health perspective, the Behavioral Health Task Force is the aggregation of so many good people working together to try to bring behavioral health to the next generation, improving access, quality, efficiency, and navigation to help Coloradans get to the programs that they need, especially during this downturn. We have so much more demand for behavioral health services. Robert will address this further, but I want you to hear from me the commitment that healthcare policy and financing has to be an active leader in this work, to be incredibly collaborative, and to bring our strengths and resources and insights and staff everything to help achieve the directives and the priorities of the Behavioral Health Task Force. From an affordability perspective, where are we focusing? The green line on the left shows price increases of prescription drugs, and the yellow line on the right shows price increases for outpatient hospital. Those are the most dramatic, and that's where we're focused. If you look at down at the bottom, you can see utilization increases as well in those areas of prescription drugs and outpatient hospital. If you combine those two, utilization increases and pricing increases, that results in spend for employers and all of us. So we'll be focusing in those areas and continue to focus because of their impact. So let's talk about hospitals first. This slide is the aggregation. Each dot represents the averages in the state, the position of the hospitals in each state. The position of the dot represents the state's averages for profits or margins on the left-hand side, the y-axis, and on the x-axis, that is a representation of the expense control of the hospitals on average by the state. You can see the red star is an outlier representing Colorado's opportunity to lower prices. That will result in a lowering of profits and a more efficient management of expenses. So you will see the policies that we deliver and work with you as stakeholders, trying to drive thoughtfully and appropriately. That star in its outlier position, now #1 in the country for the highest profits in the country. That's where Colorado sits. And 8th position for the highest expenses running hospitals. So, and that's for discharges, inpatient and outpatient. So we want to thoughtfully move that star down towards the intersection of the average of the rest of the country. I want to recognize that this is not equally distributed, that we have our rural hospitals have a negative patient margin. That means for patient income to pay for care, it's a negative margin in our rural communities of 5.4%. In the urban areas, it is a positive margin of 9.8 or 10%. So the difference between rural is negative 5.4 and positive 10 is where we have to recognize we have different strategies that we have to employ to help our rural hospitals get to tomorrow, because without assistance, it is hard to have a negative profit level and be able to invest in tomorrow. So we have to help our rural hospitals rise and transform, invest in our rural hospitals while we're working with the front range mega systems, bigger systems to move that star thoughtfully, carefully down to the averages of the rest of the country. I also want to recognize and thank the hospitals for their performance to date, and recognize that the slide I just showed you was from 2018. In 2018, 2019, or 2019, 2020, our hospitals have been working to make more strategic decisions to lower prices and to improve affordability. We look forward to the continuing data that we collect to show and to recognize the hospitals who are part of the solution of working so hard to drive expense efficiencies and affordability. But I also want to recognize that and thank Representative Kennedy for his good work and leadership in passing 2 bills in 2019. One was on transparency around the financials of hospitals, and the second is around their community investment. All hospitals in Colorado, with the exception of HCA, don't pay taxes. They're not for profit. So we have transparencies, reports understanding that this first report, they'll come out at the end of this week, between 2014 and 2019, the average net patient revenue, which includes those high prices, increased by 33.7% during that time, $4 billion, 6% a year, while charity care went down by about 11%. From a community investment, we want to recognize, and we'll learn from Will Cook, how can we look at all the hospitals in the aggregate, and as a society, as our stakeholders, identify areas where we want to aggregate and focus. It might be homelessness, maybe it is food supports, maybe it is affordability, but how do we want to be a better strategic partner in pulling together focus, perhaps in behavioral health areas? And you'll see that about $1 billion from the hospitals in their community contributions went to reducing cost of care for those that are not covered or providing free services, while about $800 million went to behavioral health, social determinants of health investments. I also want to recognize and thank the hospitals for their collaborative partnership in the HTP, or Hospital Transformation Program. Through that program, healthcare policy and financing uses about $1.4 billion to reward hospitals for transforming to the betterment of Colorado families, Colorado businesses, and healthcare policy and finances Medicaid program. We also have in there, which Nancy Dolson will talk about in a future session today during our summit, the $12 million a year, $60 million to help our rural hospitals more favorably transform. You'll see the Polis administration and health cabinet also focus on driving a new normal to help our employers, families, and Medicaid drive a better tomorrow from affordability and outcomes. We'll ask hospitals and reward them through those alternate payment methodologies in the hospital transformation program. Reward them for shutting down standalone emergency rooms or repurposing them, for example, turning them into behavioral health access sites. We'll reward the hospitals for implementing prescriber tools and other physician tools that help us improve affordability. We will continue to invest in alternate payment methodologies and drive telemedicine for the betterment of behavioral health access, access for people with individuals with disabilities or our older adults. As well, we should expect that as we recognize the lower cost of goods sold or expenses affiliated with telehealth, that we will look for a different pricing model to recognize the difference in that and to drive affordability and appropriateness of care. I want to recognize that Javier Becerra is the new HHS appointed cabinet member for President-elect Biden. And we want to recognize how his philosophy and values are aligned exactly with the Polis administration and the health cabinet. So I want to recognize that he was the one that defended during the Supreme Court hearings the ACA, which is aligned with the health cabinet's intentions to drive continual membership to keep people covered through affordable care through our marketplace exchanges. We are cautiously optimistic that the decision that comes out of the Supreme Court in May or June will be favorable, and depending on how it actually is defined in the end, that decision, we're confident that we'll be able to manage through without any catastrophic consequences for sure. But we do want to recognize there are more than 600,000 Coloradans getting affordable coverage just because of the marketplace exchanges and Medicaid expansion enabled through the ACA. That doesn't include the reinsurance that drives a savings at more than 20% in the exchanges. That's funded through the ACA or young adults up to age 26 on their parents' programs. We want to recognize that Secretary Becerra is also aligned with overall affordability. Here's a quote from him: "We are in the midst of a global pandemic, so it is more important than ever that we make healthcare more accessible and affordable to patients who need it." That aligns exactly nearly with what Lieutenant Governor kicked us off with. From a drug manufacturer perspective, we should know that Secretary Becerra is holding the industry accountable as exemplified with his leadership in the opioid settlements. From a hospital perspective, he is aligned with the departments and the health cabinet's perspective of making sure that the grand mergers that we've had in this state, which parallel California, where he is the AG, and went through a legal suit with Sutter Health, which is one of the largest systems, not-for-profit systems in the state, and went through a settlement to correct their anti-competitive practices and to recognize their price increases, which were not in the best interest of Coloradans. So his interests are aligned with Colorado's, and they're aligned with our hospitals' intentions of being part of the solution and the good work that they are doing to bring prices down. And that is specifically in accordance with mergers and acquisitions. So in our state, we've had, in 2009, we had 7 hospital systems that represented and owned 26 hospitals. We now have 6 hospital systems that own 48 hospitals, almost a doubling of those hospitals that are owned by big systems. We should also expect for the stakeholders on the call that we as a health cabinet and the Polis administration are supportive of General Assembly's pursuits of state-based insurance options. Some might call it a public option. And we should also recognize that the difference in the last decade for the number of Coloradans who are covered by public programs is night and day. So in 2009, we had about 10% of Coloradans covered by Medicaid. In 2020, we have 24% of Coloradans covered by Medicaid. That's a 250% increase. At the same time, Medicare in 2009 was about 10% or 9.7% covering the population. It's now 16%. That's a 66% increase. Just those 2 programs, not including TRICARE and others. That's more than 40% of the population is now covered by public programs. And the affordability challenge is not in the public programs, it's in the commercial programs. So we will learn to lean on and to work together to drive affordability together and look for those emerging initiatives. We will also focus on health equities. And you can see on the slide that the COVID outcomes have been tremendously different between people of color and white individuals, and we will drive those disparities down and close them by addressing health equity. And we will do that by getting more money from the CDC to make sure, first and foremost, that individuals are vaccinated and that we don't have a difference in the vaccination rate and uptake for people of color and white individuals. So we'll look for the CDC for more money. We have a state stimulus package already on the table to close healthcare disparities. I want to thank all of you on the phone for your partnerships in leading this work and to drive for culturally sensitive care, critical as we go forward. Now I'm going to turn our lens to prescription drugs. We released yesterday about a 100-page report that went through tremendous detail of how we drive policy to recognize this top driver of rising healthcare costs. Well, to do that, we've got to understand where's the spend coming from. So here's Medicaid up at the top, and here's all payers. And so you can see about 45% of the number of prescriptions being prescribed are generics. That's good. And they represent somewhere between 13 to 20% of the overall spend. If you look at the brands, about 14 to 15% of the drugs drive about 40% of the spend, but specialty drugs, less than 2% of the prescriptions prescribed to Coloradans are so expensive that they're driving now 48% of Medicaid spend. That 2019 commercial only number was 49%. We're coming into 2021. It is a sure thing that specialty drugs are now representing more than 50% of the spend. So now we're going to spend some time saying, look for the bright colors. That is where we're focused. What are the solutions that we use to drive, to address the drivers of rising healthcare costs? So drug prices are affected by a multitude of levers. It is complex. There is not accountability. So you should look to Affordability Board as a solution in Colorado. The Affordability Board is a group of individuals appointed that would help us identify and study the costs and prices of drugs and set upper payment limits. We're going to hear more about that in the other sessions. We can also influence federal pricing at the federal level. The overutilization of high-cost drugs, we can address that by reducing and limiting direct-to-consumer marketing, the marketing to physicians, by sharing and passing through rebates, and giving prescribers tools so they can see actually the cost of drugs and work that into their equation of what they prescribe. Drug importation, following Medicaid policy, again, an Affordability Board, and patent exclusivity can help us address the fact that drugs in other countries are significantly in our country, significantly higher priced than other countries. We want to especially focus on the perfect storm associated with high-cost drugs that come to market without an FDA control of price. And at the same time, patent exclusivity can help drug manufacturers have decades of periods of time, decades without competition and generics coming to market. Those two things are a massive driver of the affordability crisis we have, and we can correct and acknowledge that and address it through affordability boards, through importation, and through learning from Medicaid policy as well. I also want to recognize the importance of transparency and the prices that are set potentially by the FDA or collaboration with CMS during the approval process to address those high prices. We also recognize that we can use value-based contracts and a interruption of the current federal incentives for manufacturers. So instead of just focusing almost solely, more than 75% of the focus in manufacturing drugs that address only a small part of society and are pushed to market very, very quickly, that we change those incentives. This vaccine coming out is a great example of having a more broad focus on the drugs that are actually coming to market. We can also pass through rebates to bring relief to consumers and to businesses, passing by the middlemen who often retain them in the form of profits. And we want to make sure that we recognize that the difference in pricing that PBMs and insurance companies give small employers is very different than the pricing they give to larger employers, which, by the way, is different than the pricing that we get here at Medicaid. We want to recognize and look out for the small employer and allow that small employer, invite them to collaborate in coalitions to negotiate better deals in pricing and to give them to the deals that they actually want to negotiate. So we're going to share just a couple of specifics. So I want to recognize that the policy that drives Medicaid reimbursement is very different and has a very different outcome So I want to illustrate what I mean here. If you look at the second column from the right, the difference between the per member per month cost between 2014 and 2019 went up more than 50%. And that parallels employers having the same threat from the dramatic stranglehold that rising prescription drugs have on their budgets and overall healthcare costs, over 50%. But when you look at the policies set at the federal government and how they then affect the net result of the cost of prescription drugs, our Medicaid costs are down 10 to 20% during the same time. That is dramatically different. It's a rise of 50% versus a reduction of 10 to 20%. So let's look at where that comes from and what we can learn as we establish policy and learn from Medicaid. Medicaid has the right to best prices. If the Affordability Board in the state set a lower price, we would have the right to that price. So if manufacturers gave a price or an affordability set, we would have the right to that price. Medicaid rebates, we get a special rebate from manufacturers when their price increases to the market go up more than inflation. So we have increases across brand, specialty, generic. When those increases go up 10%, 15%, 20%, the manufacturer has to give Medicaid back a rebate that neutralizes that increase down to about 1%. That is dramatic and a huge reason why we have the savings that we do. That means the increases in employer cost on prescription drugs are due to those increases. Combine it with the highest cost drugs coming to market without a price control and increases that are not controlled. And that's why you have this affordability crisis. And we're not having it in Medicaid because of the unique policies we have. We also have unique policies that 100% of the rebates have to flow through. I want to close with a couple of final thoughts on prescription drugs. We did a study and are right now in the process. In fact, this month, an invitation to negotiate will go out to Canadian suppliers to help us import drugs at Canadian prices. And if we do that, we'll save more than 60% of drugs coming in that are allowed under federal regulation. If we were to open that up with an opportunity to policy in this session, we could save an additional almost 80% if we pull drugs from Canada or 84% if we imported from France. I also want to recognize we want to import biologic. Why is this important? Humira, which has had a patent protection for more than 2 decades. The prices in Canada are 67% cheaper. In France, 79%. In Australia, 74%. Trulicity, which is a diabetes drug. Prices in Canada are 88% cheaper. In France, 84. In Australia, 91. Let me translate that. We're paying 10 times the price that France is, that Australia is for that same drug. Thyroid, same thing. 93 to 95% savings between Canada, France, and Australia. Let me translate that. We're paying 20 times the prices of other countries. So can we as an affordability board recognize the insight or can we import the drugs themselves? Tom will talk about the prescriber tool in the next session, but it gives physicians insights into the affordability of drugs and also helps them reduce the chance of addiction. We have 5,000 free licenses, which Tom will talk about in this next session, available to physicians to put a new module to prevent opioid addiction. From the rebate pass-through that we talked about, what's the value of those rebates? It's about 22% of branded drugs, and it's about 18% of specialty drugs. What does that mean? If a new drug comes out and it's $500,000, it means the manufacturer is paying to the middleman, the carrier of the PBM, about $100,000, and they may or may not be passing some or all of that through. We want all of that to pass through to employers and consumers. I also want to recognize that specialty drug rebates have gone up since 2016 to 2018 in the study by 67%, and that the commercial rebates have gone up, but from 11% to 16%, which is a 50% increase between 2016 and 2018. So we've got to pass through those rebates to bring relief. We also want to invite the Colorado Purchasing Alliance. You might know Bob Smith's good work on that. He's in one of the sessions today as well. We want to recognize and show employers, here's the best in class pricing. Bond together to drive to this so that the small employers do not, the middleman, the insurance companies and PBMs are not making a markup on the pricing that they're providing to the small employers, that the small employers are getting a better deal. I also want to recognize the opportunity that the industry has purchased in between carriers and PBMs. Cigna now owns Express Scripts, CVS owns Aetna, and Optum is an owning of United Health Group, and the profits have continued to soar through the last decade. If you want to look and have an eye to where the health cabinet and the Polis administration is going from a policy perspective, you can look to other states, affordability boards, importation, transparency and accountability and cost controls and transparency that drives good policy, rebates, and holding the industry accountable, PBMs, carriers, and the like. With that, I will turn it over to questions and invite the Lieutenant Governor to join us. And we're going to take about 2 minutes of questions. And the bulk of the questions can come from the other sessions or follow-up. Follow-up sites, we will aggregate all the questions that come in and come out with the answers to those most frequently asked questions. So I'm looking here at some of the questions. So in the pursuit of affordability, where is the state in the pursuit of a state or public option and or the total cost of care legislation? I would invite our elected officials to have broad dialogue with the Department of Insurance and Commissioner Conway, myself and other stakeholders to pursue and to identify what is the best pathway. We do have ideas and concepts and are in collaboration with some of our elected officials, but this should be a good dialogue of both of those coming together, setting some targets and having good stakeholder engagement to, should we set targets, and then do we give the industry some time to engage to hit those targets? Do we do a different pursuit? I think all of those are on the table. DJ, just give me a little thumbs up when you want. I think you said, I think we've got about 2 more minutes or so. Is Lieutenant Governor on? Has she joined?
Yes, I am,
Okay,
Kim, and I just would like to add, I would like to add to your answer that, you know, when the governor and I started the administration, all ideas were on the table for how we could lower healthcare costs. And I think public option is another one of those ideas. And of course, as you have mentioned, we're open to more and we want to dialogue and do whatever we can to lower healthcare costs, whether it's prescriptions, whether it's insurance premiums, whether, you know, whatever out-of-pocket costs the person has is what we want to work on.
Wonderful. Lieutenant Governor, I'll throw this one to you as well. I'll take a crack at it and then I'll throw it to you. Kim mentioned the stimulus money to help in health equities. Can you say more about that? So HCPF put forward a stimulus request for $1 million, and with our relationship with the federal government, we can turn that into more than $5 million. We met separately with the Center for African American Health and separately with the Health Foundation to get an agreement on some of the initial items, which is where you're seeing the COVID and the maternity come from. But we can use that to get a better insight into getting the right data and foundational information so that we can actually identify the healthcare disparities. Much of the healthcare disparities that I'm quoting are coming out of federal information, national information, not necessarily Colorado information, but is a deeply passionate area for so many of you on the phone. And Lieutenant Governor, I would open it up to you to add any comments to that.
Yeah, and I think, you know, one of the, as you said, one way the state has lagged is collecting data on equity and that kind of thing. And I know Carrie Paykosh, the director of the Office of eHealth Innovation, will be one of the people you'll hear from today. And I don't know if she'll touch on that, but we do need to, you know, bump up our data collection so that we know exactly what the problem is. We also need, you know, it's been said it's one thing to invite someone to the table, but it's another thing to set the table to help make them want to participate. And you know, we want to make sure that we involve stakeholders from these groups that have been so marginalized to have them help us come up with solutions to this problem, because it is something that the governor and I are very interested in looking at. And in the state, we've formed an equity, diversity, and inclusion task force to look at different things that impact people throughout our state system. So it is a lens that we're really, really looking through now.
Thank you, Lieutenant Governor. I'm going to address two at once here. Importation, there are 2 questions. What is the anticipated time frame? Again, the invitation to negotiate is going out now. We hope to have it up and running in late 22 or 23. And then the question is, personal experience says that imported drugs from outside the U.S. are typically manufactured at the same locations, not in the U.S., and then sold into the U.S. and other countries. Do you see that, Noel? And the answer is yes. Tom will address that in the next session. It's the same drugs coming in at the same FDA standards, and we're pretty confident in that. Let me look for another one. Lieutenant Governor, I'll throw this one to you. The rural community and stakeholders are saying, what can be done to opened additional urgent care facilities on the Western Slope. It appears that individuals in the ER could be redirected if we had more urgent care facilities or physicians that cut costs or had expanded hours. Do you have any insights on that or thoughts that you might want to share?
Well, I know this is something that your staff have looked at and tried to figure out. As people may or may not know, my chief of staff is from the San Luis Valley, and she is a constant reminder to me of how important healthcare is in the rural areas and how it really lacks in many ways. So, I know, Kim, one of the things you've talked about is community need. And if I think a community need can be shown that this really is something that is needed in that area, it's definitely a discussion we could have.
Thank you. And I will underscore that we are in the process, Michelle Mills will talk about identifying what we'll call centers of excellence until we rename it something else. But how can we provide increased access in the rural communities for specific types of care? So developing cancer treatments and chemotherapy treatments or cardiac treatments or orthopedic treatments. And we can add this to the list of right care, right price of the rural clinics and turning them into longer hours. So that can be part of the transformation of our rural hospitals and the investments that we make to help them get to a better tomorrow for access, quality, and affordability.
And the other thing that we've done, Kim, and I know we're coming to the end here, is we've put a lot more emphasis on primary care. And I think oftentimes people wind up in urgent care or the emergency room because they don't have a medical home of any sort. And I think if we can get people the preventive care that they need, as you mentioned, the right care at the right place at the right time, this would cut out on our emergency use and our urgent care use. So that's another thing this administration has really taken a serious look at, is more investment in primary care.
Okay, wonderful. We'll have two more and then we'll turn it back over to DJ here. One of the things I'm most concerned about is disparities in culturally competent care in physical health and especially behavioral health. So Lieutenant Governor, I'm going to turn that over to you because I know that is an extreme passion for you.
Yeah, the Colorado Commission of Indian Affairs is in my office. The director of that is in our office. So, we are in touch with the Ute Mountain Ute, the Southern Ute Indian tribe, and, we are really getting an understanding about the disparities just in their healthcare system. So, it's really important that people feel comfortable with the provider that they go to. And this isn't just a cultural thing with people of color. We heard loud and clear from people from the deaf and the deaf-blind community about their culture and how difficult it is for them to access services, especially in the behavioral health realm. And so we have a lot of areas that we need to really work on to make sure that people feel comfortable and get the kind of care that they believe, they want from our system.
Okay, I'm going to answer the last one and turn it over to DJ. This question is, Kim mentioned the importance of passing through savings and rebates and discounts. Can the state ensure that this goes straight to the patients at the counter so people with chronic conditions aren't subsidizing everybody else's premiums? Two thoughts on that. I think there's an opportunity for sharing in that. We want to be careful that, that when you pass along manufacturer rebates, that you don't actually eliminate the cost for the highest cost drugs to consumers and actually create then a cost share on generic drugs. So we have this out of line incentive, this inappropriate, misaligned incentives, what we actually want. So there's an opportunity to be very thoughtful of how we share those big monies to get the right outcomes. And with that, thank you, Lieutenant Governor, as always, for your leadership and your help kicking us off, helping me answer hard questions here during this session. We will address all of your questions in the major categories and send them out at the end. And with that, we'll turn it back over to you, DJ, to kick us off for our next session.